Do you know that area?
No, not really. So it's on the Kona side.
On the
Uh,
Kona side, as far north as you can go.
so I actually have driven up that far,
Did,
but I didn't know there was a town called that. So I've gone as far as you can go with that
so
direction.
you probably went out to Pololu, the valley.
Yeah.
And just before you got to Pololu, about 5 miles, you drove through a little town, Havi, but you probably blinked. Yeah.
Next time I won't. That's
it, you don't want to. It's very special.
Yeah.
Very sweet community. Yeah.
So, hi, Jerry. How are you? Are you there? You're muted, I think.
I'm going to learn this by the time this is all over. I'm going to be a pro at this.
You will.
I'm fine. I hope all of you are well as well.
So, Jerry, right above you, I don't know if the screen's the same for everybody, but right above you is Jake Eagle. Do you see, Jerry, you see Jake?
Yeah. Hi, Jerry.
Hi, Jake.
If you two get a chance to meet each other, so Jake has been doing 20 to 30 group sessions of 20, 30 people at a time for a while. He's a pain specialist. And I was telling Jake that you were doing the group therapies at IPS. And then next week, I hope if it works out, you, Les, and Sue, we're going to talk about oxytocin and group therapy. And I'm sort of excited, and Mel, did you do group stuff in Las Vegas by chance? Are you still doing those? You're muted there, Mel.
Group is the most effective tool for people with chronic pain and with addiction as well.
Right. I mean, I honestly think it's interesting because the group setting is extraordinarily powerful. And then I'm sort of excited about, I'm still not much on silly to you, but Mel, I haven't heard much about oxytocin in chronic pain. Have you, Mel, or anybody?
Not till I got here.
So I'm sort of excited about, we keep seeing these incredible results in the group setting with chronic pain. And it could be the secret sauce is the oxytocin. It's really interesting. It's fascinating. Hi, Shauna. You're muted. Hey, Jean. I don't know you very well. Yeah, I saw you once before.
Hi, David. Hi, everyone.
Hi.
Oh.
Hi.
Hi, David. It's Jen, and I'm without video tonight.
Okay.
I tend to lose my connection sometimes, so it seems like without video in the really large groups, it goes better. But yeah, I just wanted to jump in too and say, we've really never talked about oxytocin in chronic pain. In the years that I was treating it and working in clinic, it just never came up. And it wasn't even on the radar screen. I mean, it was like, it was something about pregnancy. That was it.
Right. Com, are you doing group settings in your spine zone stuff down there? And you're muted.
Oh, sorry. Yeah. Hi, David. We are starting to do some groups. We have been doing group sessions for the past few months with Les, and prior to that, we were doing with the UCSD mindfulness group.
Right. So yeah, no, I just think it's so clear. Again, we sort of ran across by accident back in Omega, where Babs and I and my stepdaughter started doing these group sessions together. And as opposed to the medical model where you're doing like a pain clinic like this and this approach, is all about the structured environment, shared setting, people feel incredibly safe, and they were sharing enjoyable experiences together. And in 3 days, the group would go to almost the entire group went to pain-free in 3 days. I mean, Susie, you were part of one of those in Seattle. I mean, what was your general feeling being part of that 3-day process?
Very, very powerful.
Yeah.
Much more so than individual, I think. Yeah.
So one of my agendas here, if we can start linking to the oxytocin, the group therapies, I mean, I just honestly think that some type of group setting where it isn't just about, let's do CBT and physical therapy, et cetera, but truly creating connection, I think should become the standard of care for chronic pain. I think it would make a tremendous difference. It's not like most people in this group have actually had a lot of experience with that. And Shauna, you've done that a lot too, correct?
Yeah, I mean, it actually is not just like thinking about the groups of warriors that I've walked with in reunions, but think about the whole experience of combat as having some of the same, I think, effective ingredients as what makes group therapy reduce pain. That the group going through the process together and metabolizing it as a tribe is something that really has an impact. So happy to see what comes up with that. But so excited to bring Gene Lipov on tonight. He's just my buddy and just like an amazing just innovator and pioneer in the space of the sympathetic blockade for how we manage the fight or flight system. So I'm going to ask him to take lead, but I'm going to jump in because we've had this really unique partnership. And I want to talk to you about how we've really made a team approach to medicine, not just empty words. Gene, are you able to start us off?
Where is Gene?
He's muted. Gene, can you unmute yourself?
And do you have his slides, David, or Gene, do you have slides?
Gene has a slide. I can put them up if I need to do that.
Yeah, either way. I mean, I can do it with slides or without slides.
Let's put your slides up, but we're trying to go at half an hour with lecture, then try to keep it open for questions in the
Sure.
last half hour. Can you put your slides up and I'll let you screen share with me?
I don't know how to do that.
Maybe let's see if I can find your slides really quickly. Why don't you start talking? Why don't you start talking while I play with this, and then I'll get this up while you start.
I have the slides. I just don't know how to put it up. Usually somebody else does it for me.
Gene, at the bottom it says share screen, a little green button in the middle.
Share screen, got it.
Click that, and then we should be able to see what you're seeing if you open your slides up.
Sure.
Yep.
See if that works. Does that work?
Not yet.
I'm seeing it on my screen here. No?
What do you
Did
think,
press
David?
Did you press share screen?
I made it so more than one person can share the
Okay.
screen. You're seeing mine, right?
Yeah, I see yours.
Gene, do you have
so
do you have two
if you can-
monitors?
If you can now hit share, if you can also
I
I'll
hit share.
stop my share. So now if you hit your share, you should be able to put your slides up.
Okay. Okay. Okay.
There you go.
There we go. All right, and you can actually start slideshow. You did it. Gene and I teach each other tech tips because, like, I'm not a tech person
Crazy.
either. Yeah.
Crazy. Well, first of all, thank you very much to everybody, especially Dr. Porges. He has been my buddy for a long time. He, it's funny. I don't know if you guys know the history how we met, but somebody wanted to introduce me to the master of parasympathetic system since I was working with sympathetic system. I went in to say hello, and 4 hours later, I came out quite overwhelmed by the experience. It's an amazing man. Anyway, off we go. So stellate ganglion block. So I'm a pain physician, so I find it very interesting that you guys were talking about oxytocin as a shared experience, since I'm one of those people who sticks needles into people. So, I mean, that's for another day. Anyway, so what I wanted to do today is kind of go over where it all started, where we are today, and some of the caveats, what we're learning. So the first time I did stellate ganglion block for PT in general was in 1990. First time I did it for PTSD was 2005, which was a civilian gentleman who was robbed at gunpoint, and he was on his way to be admitted to psychiatric ward 2 months after the injury. So stellate ganglion block has been done since 1925. It's pretty well understood. It has been evolving. I was trained to do it blind, and then fluoroscopy, and now I'm getting into the ultrasound, and I'll show you the differences. And
So,
there are
Jane, could you do us a favor? Some of the group is not necessarily familiar with stellate ganglion blocks and the theory
Right.
behind it. Could you explain to us where the stellate ganglion exists?
Of course,
what it is?
I am getting to the slide.
Oh, great.
That's why I like pictures. So here we go. This is a cross section of the neck at C6. Technically, stellate ganglia is at C7, but most people do it at C6 at this point. So it's essentially front of the neck right here. So we started doing right-sided because the left-sided was not as effective. So if you look at the slide, that's the needle going in. This is how I was originally trained. Take the carotid artery, pull it out of the way, and put a needle down. Hit thoracic tubercle, which is one of the bony ridges in the neck, and inject 7 to 10 cc's of something, a local anesthetic. And usually you see a Horner syndrome, which is droopy eyeball from that. So it's basically part of the sympathetic chain, which is a fight and flight system. So until I start looking at it in detail, people in pain medicine has always thought the reason to do the stellate ganglion block was for a hand of CRPS, complex regional pain syndrome, which is basically burning of the hand. So they thought that it affected the hand and the arm, but not the brain. So through interesting research, actually, we'll talk about neuroscience about it, but essentially that's an injection in the neck. Is that pretty clear to everybody, or should I get more detail?
Well, quick question. So just to be clear, we have the sympathetic nervous system, which is the threat, fight, flight system. And again, I don't know much about stellate ganglion blocks myself. So remind me personally exactly what the stellate ganglion is.
I can show you on the neck. So if Gene hit me right here, because you can't see your neck, Gene, it'd be right about here on the neck is that cluster of nerves where
I'm
he's
trying to get a better view here.
So the ganglion is a series of cell bodies in one spot, correct?
That connects, exactly. There is a synapse there, and from there, post-sympathetic fibers go to the brain, ascending to the brain via vertebral artery.
And does the block affect the entire sympathetic nervous system below the block, or does it go proximal and distal both, or
No,
how much
fair
of the sympathetic system does it?
So let me give you a little more detail. I understand your question. First of all, there is no cervical sympathetic fibers at all. There's no sympathetic fibers in the neck.
Wow.
So
Okay.
nucleus ceruleus, which is the base of sympathetic system, comes out of the brain, goes down the spinal cord, and sympathetic fibers leave the spinal cord and connect to ganglia or form ganglia. So the highest level of cervical of the sympathetic ganglia in the thoracic is T2 level. From T2 level, the nerves further on go up to C7 and T1, which form one ganglia called stellate ganglia. They go up to C6 ganglia, which is middle cervical ganglia, and then superior cervical ganglia, which is C3. Did that answer your question?
It does. DR, are you there for a second? So DR and I have had this question. I'm embarrassed to ask it because I should know something being an orthopedic surgeon and medical school. So what we've been learning from Steve Porges, of course, you have the vagus nerve and the dorsal and ventral nucleus, but it seems like there's still a sympathetic nervous system all over the entire body. It seems like there's a baseline sympathetic tone that's not necessarily regulated by the brain. The regulation seems to occur with the parasympathetic system. So we don't quite understand. So, dear, am I asking the right question there?
Well,
Yeah, Steve.
I'll go, buddy.
Yeah, maybe.
Okay, so there's an interesting issue here, and that is, and it's not easily found in the literature, and I keep asking this of Gene, and that
Steve,
is the.
can you crank it up, buddy? I can't hear you.
Okay. Can you hear me now? I think I know the problem. Let's get this working. Okay, this is better, right?
Yeah.
Oh, yeah.
Okay, that's
beautiful.
because I had the other microphone. Okay, that's the problem. Okay, so the question really is the phylogeny of the ganglia. And so in a sense, from a polyvagal perspective, everything is based upon the evolution of the system. And I still am trying to find out about the cervical ganglia and the evolution of whether do you see them in reptiles, or in a sense, is this a mammalian innervation of a sympathetic nervous system that becomes the parallel, what I call the social engagement system, meaning the part of the vagal system that is linked to the feedback from the cranial nerves of the face and head. And so this becomes an open question. And so I actually, always kind of pepper Gene with some of those questions, but I tried to go back into the literature today and I couldn't find anything. And the other point I found, and this is what I was going to ask Gene, is the morphology of the stellate ganglia is not as simple as one thinks. It's apparently a fusion of two ganglia, and that in a sense gives you some hints.
So if I may, that I know. Actually, morphology I know pretty well. So it's very interesting. So the ganglia is very strange. It forms in a totally different part of the neural tube. So the largest cervical ganglion is actually superior cervical ganglion, C3, which is higher up here. middle cervical ganglia, which is where most people put the needle at C6 level, exists only about 50% of the time.
Mhm.
So what people call stellate ganglion typically exists in dogs usually. That's why it was originally described, it looks like a star. But that technically it's a fusion between C7 and T1 ganglia.
Mhm.
But the reason people can do C6 and get away with it is because it's a field block, in a sense that if you do an injection in front of longus colli muscle, the medication spreads up and down. So when you do C6, which is safer because there's no lung there, the vessels are not as bad, then it can spread up and down. So morphology, I can send people who reached it. I have an old book from 1956 from James Moore, and he did 12 dissection. The variety of they look like, they looked very different. They're not the same, nothing like a textbook.
So the question, so Steve, what I'm asking is that, okay, and DR, stop me if I'm way off base here, but our impression is that there's a sympathetic tone in the body that's sort of constant, and that Steve, you said that the heart rate would be between 140 to 160 without
No,
parasympathetic.
without neural tone to the heart, it's between 90 and 120.
Okay.
But you have a chronic vagal inhibition to the heart. That's a vagal break. So our heart rate's in the 60 to 80 range. The part here is you're trying to reach for a feedback loop in your thinking.
Right.
And you have to think, that's really what I was reaching for too, whether the ganglia, whether we're talking about superior cervical ganglia, the middle, or the inferior or stellate ganglia, whether they're really the opposing system to what I would call the ventral vagal circuit, which links the neural regulation of the striated muscles of the face with the myelinated vagus to the heart. So whether that's actually a feedback loop. And when Gene had this phenomenon, I said, aha, what he's doing is this system is out of balance. So the sympathetic tone is so high in these individuals that their ventral vagal system is dormant. And that if he knocks this out in a transitory way, the system automatically retunes, and then you get facial expressivity, intonation of voice, and spontaneous social engagement and calmer behavior. And that's what he was seeing. So I was always interested in that metaphor, and I'm trying to, in a sense, build the neuroanatomical model that would, in a sense, say that what he's doing is dealing with a newer mammalian sympathetic innervation, or that just has been in a chronic state, and he needs to be retuned in a transitory way. But I don't know if that type of hypothesis is really plausible, because I can't find any information on the phylogeny of the ganglia, especially of the cervical ganglia.
So Gene, I guess what I'm asking, when you block the sympathetic system, so again,
no, let's say he blocks on the ganglia level. So you have to ask, you have to, in a sense, refine the question. He's blocking a specific locus of sympathetic tone, and then emergent properties occur.
Okay.
So let me just push on that for a second. So what I'm doing, actually, we're blocking the ganglia and post-sympathetic, post-ganglionic fibers, as well as preganglionic fibers. So what I'm actually, in a sense, I think I'm blocking is sympathetic supply to the right side of the face and the amygdala and the insular cortex. That's what we're doing.
So Gene, that's exactly what David wants to hear. You're blocking an efferent pathway, which you see when you look at the individual, but it's affecting, because of its afferent pathways going up to the higher brain structures, it's causing a feedback reorganization.
Could you explain, Gene, like the piece about how the nerve growth factor operates to produce extra nerves that this prunes? I think that's the missing link for people to really understand.
I'll be happy to get, let me see what David had to ask, because what Steve was bringing up is a way different perspective versus my explanation. Keep in mind, Steve is giving a different explanation than mine is. But they both can be true. One of them could be true. I don't know. I will get to my explanation for sure.
Okay.
Dave, do you have a question? Thank you, Shona. Or David, did you have a
No,
specific question?
we keep going. I think I'm following you so far. So we basically have a
So
sympathetic.
basically, what I was trying to do, in 2009, I wrote a paper trying to explain why would stellate ganglion block that lasts 8 to 12 hours give relief in some people up to 10, 20 years, 10, 15 years is the longest outlier right now. So I was able to find a couple of pieces of information which I think is relevant. So when there is trauma, people produce NGF, nerve growth factor. Nerve growth factor, if it's injected inside the brain of a rat, it produces sprouting, which is sympathetic nerve extra growth. Sympathetic fibers are particularly sensitive to NGF for whatever the reason. If that sprouting occurs, the NGF has been shown in the rat model to be transported retrograde from the brain to the stellate ganglia. As long as the NGF exists in stellate ganglia or sympathetic ganglia, the sprouting persists. If there is sprouting, and that's a slide 2 right here, as long as sprouting persists, increased sympathetic nerve density increases norepinephrine levels. Norepinephrine level increase has been shown in PTSD patients when they suck up their CSF and they look at that. So there is definitely an increase in norepinephrine level. So the last piece of equation, which is kind of interesting, is if you put local anesthetic onto a ganglia, it seems to reduce NGF levels, which theoretically produces pruning or loss of sympathetic fibers in the brain, the extra nerve fibers that grew, which reverses the status and norepinephrine drops. Potentially for a long term because there is a remodeling of sympathetic fibers.
And NGF is nerve growth factor.
Correct, NGF.
Is that a cytokine?
It's a neurotropin. It's not a cytokine.
And what's the difference?
Cytokine, from what I understand, is more about what I use. But I know it's a neurotropin. I can't dig into that in great detail. My biochemistry was.
Yeah, this is DR. It does.
Go ahead, sir.
It is open. Perhaps because it isn't produced by the connective tissue type cells or the white blood cells, and that may be the biggest difference. But it is associated with chronic pain syndromes, and I guess we're learning also associated with PTSD, which kind of pulls them all together. But I would also wonder what the stellate ganglion block is doing to affect the cytokine level in the glial tissue of the brain as well. I bet it's affecting equally.
I can answer that for you. So let me give you an answer to that. So we just published a paper. It came out 2 months ago in Hypothesis, which talks about the autoimmune or immune impact of stellate. So it seemed to decrease IL-6 levels. It also reduces killer cell levels. It seems to remodulate the sympathetic system. There was a paper written in China where they demonstrated ulcerative colitis symptomatology reduction and cytokinin reduction as well. So it does seem to impact on the immune system.
Yeah, and I always like to clarify, just for everybody, that the cytokines have been named after their connection with the immune system and their ability to stimulate cellular migration in white cells. But they have endocrine properties and metabolic properties and neurotransmission type properties as well. So they do a whole bunch of other stuff other than just attract white cells to targets.
If you have a paper on that, I would love to see that. I know very little about that, frankly. I've never looked in that detail.
Sure. Yeah, I'll get one up.
Somebody's having a good day.
Yeah. So you kind of not quite following my little path here, but I would like to show you this one paper from 2015. So there was a study done by Dr. Alkire, who's a professor of anesthesia in Irvine, a marvelous man. And basically what he was trying to do is to do a PET scan assessment of severe PTSD patients in Long Beach, VA, to do stellate ganglion block, and to do a follow-up PET scan few days later and see if there was a change in symptomatology and a PET scan. And he was able to demonstrate that the right-sided amygdala and hippocampal area are relatively overactive in PTSD symptoms, which I assume everybody knew. Dr. Librazan published that in 1984. And then the more the CAPS reduce, which is like a PCL or the questionnaire, CAPS is including psychological assessment as a diagnostic for PTSD, it was correlated with changes in the PET scan, which is the images here. I cannot tell you I'm a very good person to read those, but those interesting, I'll be happy to send you that paper. That's a single study. So in fact, we are talking, Shona and I are talking to a big institution right now, trying to get a functional MRI study before and after a stellate, because there is a huge need in objective assessment of the impact of stellate ganglion block, because that's part of the reason it's still not as widely accepted as it could be.
Yeah, Gene knows all about the morphology and the systems and the theories. I get the calls from multiple deployed combat Marines who say, I'm done. And I say, hold on, would you just try this one more thing? And I send them to Gene in Chicago, and he puts the injection in their neck. He does actually a 2-block sequence that nobody else is doing that we find is really the game changer for them. And then they tell me repeatedly, and their wives tell me, oh my goodness, what did you do with my husband? And they say, it feels like I've had 1,000-pound weight lifted off my chest. I feel calm in my own body. They have these interesting experiences where they see colors more vividly after the injection, and they see more of what's in their sort of like visual array, which makes total sense to me, because that to me is like the tunnel vision of being in chronic threat response, in that chronic locked in state of fight or flight, where they're chronically dysregulated for years. They now feel calm in their own bodies, and they're more open for connection with their loved ones. And so one of the quotes was from a recent Marine that Gene treated, was he walked around Chicago afterwards and he said, I forgot how beautiful the world is when my brain stops telling me that it's trying to kill me. So that's the outcomes of all of this procedure, that I couldn't explain the physiology, but it's saving the lives of people that are the hardest hit, the most traumatized. And my part in the arrangement is to prepare them well, because if you don't do the work on the front end to prepare them for the procedure, you're sort of swimming upstream against that tide of like fight or flight, like adrenaline. We don't want that. We want them to go in as calm as they can, knowing everything they can, using that opportunity well. And then afterwards, when they're calm in their own bodies, it opens up this window of opportunity for them to benefit from everything that I can share with them about how do you connect with your loved one. Let's develop some insight around understanding trauma and making meaning of it. And all of the psychological side of what I do is really happening when they're in an optimal mind state, not so agitated that they're at the wrong place on the Yerkes-Dodson law of arousal. So that's been our partnership, and we've co-treated about 50 cases and just had just amazing outcomes. And I'm not a true believer by nature, and it's not the only thing that works. It's not a cure. People still have to do the work, but it's been life-saving.
Hey, I have a question for Gene. And the question is, since the effects are so immediate, do you need to postulate a neural growth factor change?
Yes, because I think there are I think it's a bicuspid effect. So one, if you look at the half-life of norepinephrine in the brain is about 10, 15 minutes. So because it gets resorbed. But to me, in order to explain, so let's say it drops and it takes a little time for it to kind of reboot. Why would it last 10 years? I can't possibly imagine why this, if there is no neurological change, why would a brief reduction actually do anything?
Well, that's where you have alternative hypotheses, and that is your shifted state, and that dramatic shift in physiological state is the recovery. But that's another discussion.
Right.
The slide you just put up, it has the blockade going in the superior cervical ganglia. Is
Where?
that well, when?
Let me see. We're talking about this one?
No, the one that was up when you start touching.
Oh, lovely. Nice way of phrasing it.
Go back one. One more. Nope.
Forward?
Yeah, go forward. Patient 2, I think it is. Let's see. Keep going.
Oh, patient 3 is the one. This is a guy who had the first C6, C3 block.
Well, there was another one that had it was a superior cervical ganglia that you did in one of these that's in this montage, and I was wondering, is there a sequence you go through? You try to do the stellate, and then you go up and do a second one, or what?
Yes,
what is
that's exactly right. So let me just tell you the rationale behind it. Yeah, okay. So let me show you the picture, which will make all of this make a lot of sense. So this is a picture from Dr. Moore's book. So if you look at that, so sympathetic fibers lift you to go up to stellate ganglion and ascend to the brain via vertebral artery. I assume the same thing is true with medial cervical ganglion. Half of those fibers did not synapse here, and they continue on to superior cervical ganglia.
Mm-hmm.
And then those ascend via eternal carotid. So they go up to a different part of the brain based on circulation. So if you do a block at C6 or C7 and it knocks all this out, then we're good. And that means that all the fibers going up are knocked out. But a lot of times the intensity of the response is not enough. So I go up and I hit it again at C3. So first should be C6 or C7 and then C3, not the other way around.
And what medication are you using to block with? Is it like a Marcaine long-acting anesthetic or a short-acting?
Marcaine.
Marcaine.
Marcaine 0.5%.
With the epinephrine, of course, correct?
No. Epinephrine is bad for PTSD. I mix it with clonidine.
With what?
Clonidine.
Really? Okay.
Clonidine, peripherally, by mouth, is alpha-2 agonist.
Okay.
While when it's injected in perineural tissue, it's a vasoconstrictor.
And then what are the risks of the procedure? Are there any complications potentially with the procedure?
Absolutely. Let me get you to that slide. Always possible complications. I can actually just tell you. Here we go. So there was one big study done by Dr. Wolfe in Germany in 1992. This is before fluoroscopy. So this was blind, right? So they did about 45,000 patients in Germany that year. They had 14 seizures, 9 pneumothorax, 3 allergic reactions, no fatalities. There can be hematomas, which could be very problematic. The estimate right now is 1 out of 100,000. Infectious complication like osteomyelitis, 1 out of 100,000. That's pretty much the biggest complications.
And how many of these have you done, just ballpark? It sounds like you do a lot of these.
I've done 3,500 so far, probably.
Okay. And Shauna, is there, how many people in the country do these? I'm assuming this is not that widely done.
Well, pain physicians.
Pain.
I'm
Yeah,
sorry.
Go ahead, Gene. Go for it.
Pain physicians, hopefully they're all trained to do stellates. Very few do C3 block. And in fact, I'm going to be meeting with the head of radiology to optimize it. I'm trying to switch from fluoroscopy to ultrasound, which is kind of the new thing. So this is fluoroscopy. This is pretty much how it's done. So you put a needle there, you put some dye here, right? Everybody's happy. This is in front of the longest colli muscle, presumably. And then this is a new thing, the ultrasound, because this will tell you what the blood vessels are. It'll tell you what the esophagus is. It'll tell you what the longest colli muscle is. So potentially this is superior. The problem was dye, there's no dye in ultrasound. So now there are plus and minuses in both approaches. C3 is pretty difficult to do with ultrasound. That's why I'm working on optimizing technique there. Joe gets in the way to do this. But as far as how many people know how to do stellate, a number of people do it, not necessarily a large volume of it, but keep in mind, this is pain physicians' interventions. Pain physicians typically don't want to deal with psychiatric patients. It's a different type of group, shall we say, than pain.
Okay, so I'd like to open it up for questions, and then so it sounds like you have a block that lasts for probably 3 to 4 hours because of Marcaine, and I didn't really understand this. So the block works more in the central nervous system than it does distally. Am I hearing that correctly? Somehow blocking the afferents to the brain and changes the nerve growth factor and changes the to the brain. That's what I'm hearing.
That's right. It's not. This doesn't affect the heart. For example, if you do it on the right side, there's no effect on the heart at all.
Okay, so you're not worried about sympathetic block as far as blood pressure and that type of things down below. It's really so the block, the proximal effect. That's interesting.
It can actually. One of the rare complications of stellate ganglion block is hypertension.
Hypertension.
Hypertension, and I think that happens due to vagal block, which is right next to it. So if you look at the vagus, it's right around here somewhere.
Okay.
So stellate is here, vagus sits right around here.
So Sean and Jamie, any comments? I'd like to maybe have people open up with the questions. I think I'd like to have Steve maybe discuss when you might consider doing this compared to the vagal stimulator. And Sean, I'm just curious clinically if you've had a choice between a vagal stimulator and sympathetic block for PTSD, what the difference might be there.
Well, I would say that another comment I would make is that it really isn't, I would never send a patient to anybody who says I do SGB for pain at this point, because Gene really not only understands the population, but he's really innovated around, they're not using, the same medication that he does, they're not using the same technique, they don't have the whole system set up to prepare the patients or take them through the process like we do. And so we really get the effects from pairing this with the strong encouragement that people get follow-up care, because I can't treat everyone that we see, now that we're going kind of to scale. But it's really important. And he also really has tools that we didn't talk about today that he can use with the SGB that can prolong the effects. So if a person gets a good reaction from it, but it doesn't last, and then there are extra things he can do to augment it. And so he's just been innovating in this space for 10 plus years and really has kind of got the best outcomes. And so when a psychiatric patient calls me, they need it to work, because often it's kind of like the last treatment that they're considering. And so I wouldn't just send them to anybody and say, gee, let's hope it works. It really has to go to someone who's going to be very committed to doing everything he can in his innovative way to get them that outcome. So yeah, I think let's turn it over to the group for questions and see what people are wanting to know.
So if people could raise their hands, it would be helpful. I do have the screen. I can see. Jake, quick question. Jake, do you have any comments? I mean, did you do stellate blocks in your pain practice?
Are you on mute, Jake?
Jake, I think you're muted.
Yeah.
There you are.
No, my work was strictly psychological and working in groups.
Okay. Did you ever have people have the stellate ganglion blocks done, or
no?
Never did that. And Dee, are any thoughts you might have on the whole process? I didn't realize it worked proximally more than distally. What are your thoughts?
Well, my first question is because the canes are so short acting, and that the synapse in the sympathetic ganglion are actually not mediated by noradrenaline or norepinephrine, but by acetylcholine.
Right.
So my question would be, could you get a more long-term benefit? Do you need a more long-term benefit by using botulinum toxin in that location?
Well, that's a great question. It has been done by my buddy, Dr. Prieger. The problem is sometimes the anatomy here is variable. And I do know you can get at least a month out of Botox. The problem is you can hit the recurrent laryngeal nerve, which is right around here.
Yeah.
And that paralysis of that for a month is not something you want to go through.
Yeah, I will add on that. I didn't think about that, but I had a patient about probably 15 years ago who a neurologist did blocks for cervical dystonia, and he ended up trached and pegged. I don't. They obviously got something wrong in there, so there's a lot of stuff in there.
Oh my God, this is an intense area. It's tight. Yeah. It is very tight in there.
I mean, people can have the positive effects for a wide range. You've had people, Gene, that you've treated who have had one block and it's lasted for like 8 or 9 years. Some people that we've treated 6 months later, they need a second block. That one typically lasts for much longer than the first one. But it's a wide range, and maybe an average is, maybe about a year. So,
well, the first block, and we still don't know exactly the number. But the first block lasts, let's say, average is 3 months to 6 months. One after that can be for a very long time. Longest outlier right now is 13 years, 2 blocks.
Do they work for migraines?
It has been used for that. Yeah. It's not necessarily the best choice for it, but certainly can be. It's one of the things to use.
I have a
for
question.
migraines, and there's other options.
So Gene and Shauna, in terms of the longevity of the effects, have you noticed whether there were different contextual variables like relationships or?
Yeah. 100%. That's my, so like the way I would kind of describe it in everyday language is like, we've all been on vacation and then come back from a really relaxing vacation and dropped back into an extremely stressful life. And that vacation effect of relaxation doesn't last.
Yeah.
And so if you've got some,
I'm sorry. All I was going to say is, so if you take it within a state model, your clients have shifted state, and there's a certain amount of emergent properties of social connectedness and calmness. But they also have vulnerability, and that vulnerability can push them out of that state. And that's why, what you're describing, Gene's practice, and with your help, the support is really part of the critical factor, that you're getting the individual to welcome the intervention and then to have an understanding of it so they don't become reactive to it.
Exactly. So I want to educate their family members and bring them in.
Right.
Or so that there's
and not see it as merely a mechanistic causal fix.
Yes.
And I think that's going to be the critical thing. That's why if you see it as a state changer, and this goes back to David's really question, because vagal nerve stimulation can also be used as a state changer. But I would say not at this level, not with this. In a sense, what Gene is doing is turning off the defense system. It just is gone, and it's whether it's been rewired or it just is the inhibitory pathway, which is normally your vagal pathway, is ineffective, and that's really what the problem is. And that's what, when Gene told me the story, and it's a decade ago, that's what it seemed to me. And what I've been trying to do in our dialogues every year or two is to see whether we can get a good autonomic measures to see the profile, to see whether we can come up with a more integrated explanation of this massive change.
Gene opens up a wrinkle in time, and I step right into that and help people change in that critical window of opportunity, their relationships and the way they think about their trauma. the way they think about and understand themselves and how they navigate the world. So for years in the VA, I was trying to do all these exposure therapies that my patients didn't tolerate well, that they dropped out of treatment. They were all jacked up, not safe to be on the freeways in between sessions, and they were in the wrong mind state.
Yeah.
And so when they're in the right mind state, you've nailed it. Like, that's it. That's why it has to be a partnership. And that's why they need to have a combination of the medical and the psychological paired together. And their family has to be part of that. Because if they go home and their wife is not bought in on this and part of it, and she starts like resisting, or there's marital tensions or big fights or chaos, when they come out on the other end, they're back calling me in like a few months saying, it felt great for a few weeks and now it's starting to wear off. But when they have the right conditions that prolong, they can last for mine. I mean, it's been kind of more of an average of a year just within the 50 I've treated. Jean has a bigger pool to draw from, but I would say my average has been about a year.
So Jen Souders had a question. Jen, you had a question?
Yeah, so I just wanted to just to add a little bit about our experience. In my clinic, we did not a lot of these. I mean, nothing like Jean is doing, maybe, a dozen or so. But what we did have was we had chronic pain patients who we were treating for other, sources of pain, but they also had a psychiatrist. We worked very frequently with the psychiatrist. We shared patients with him and we referred. The psychiatrist would prepare the patients psychologically for this block, and they would refer the patient to us. Now, this was a patient who we were seeing for pain anyway. And so there was already a sense of safety. They knew us. So it wasn't like we were strangers. We'd stuck needles in them somewhere else already, but they trusted us.
Yes.
And what I wanted to let you guys know was not only did these people have a tremendous improvement in terms of their psychology for their PTSDs, these were all combat veterans, but what we saw, and I think David would find interesting, is these people's pain elsewhere in their bodies dropped down dramatically. Their sleep incredibly improved. The nightmares were generally gone. Their, even the anger and the perfectionism and, all of the stuff that we carry, the burden of holding it in whatever context that is, it really dropped down. And so the general effect was not only humongously psychologically and psychiatrically beneficial, but in terms of their chronic pain that was elsewhere in their body and completely unrelated, it was a dramatic positive effect. And on average, these people would have at least pain resolution for years. Some of them, it just really didn't even come back. So I just wanted to share that.
Thank you, Jennifer. I've seen that too. And so there's like, just as you say, there's kind of this direct effect on certain symptoms that seem to be addressed well with this. And those include the hyperarousal cluster of symptoms that we would typically use to diagnose PTSD. So the sleep disruption, the surges of anxiety, the panic attacks, in other words, the surges of irritability, which is interesting because Jean discovered this through surges of heat and hot flashes and sweating.
Yeah,
so that's
interesting.
A target symptom, right? And then there's also the startle response that people have and the difficulties concentrating. So those are the key symptoms that this seems to treat. But as you said, it's not just direct effects, it's mediated effects as well. Because if you have these symptoms in your life and you think they're always going to be there and there's never going to be relief from this, then all of that other stuff of like hopelessness and the pain, psychological pain of I am broken. I will never feel whole. I will never be able to connect. I'm numb. I can't, feel loving feelings for my partner. All of these things then crop up. And so the psychologist or psychiatrist not only should prepare them, but sometimes you become that secure attachment holder as you take them through the process. And so one of the things we're going to be doing is I'm going to be scoping out a whole education series for Stellate Center where Gina and I work to help referring providers understand what this is, how to use it, and I'm going to teach them how to prepare their patients for it, support them through it, and support them on the back end in a way that will sustain the outcomes that they are able to get. So we're not.
That would be great because I will say, we developed our own little protocols with one particular provider, and there was, a lot of mutual great communication. but for people to have a framework
Yeah.
to rely on, we had to really nurture it, and we were flying by the seat of our pants. And so if you had an actual, protocol framework to help practitioners work together, that would be so beneficial.
We do.
I'll
Yeah.
also add just really quickly too, that because a lot of our patients were seeing us, they were on opioids, and as we were, tapering them off, the family members would typically drive them. And so, family members would typically be present for their pain management, meetings and exams. And what we heard from the family members really reinforced that the family level of connection and the overall status of how the family's interactions were going was profoundly changed. So the family members that drove these patients to their pain medicine appointments as we actually started tapering off opioids, just reported how much better life was. Like, yeah, just what you said, you gave me my husband back.
Yeah, that was one of our patients that just called me, Sergeant in the Marine Corps, who Gene treated. And he just called to tell me, because he wrote the foreword for my book, Warrior. He called to tell me that General Mattis called him yesterday, because I asked General Mattis to call him, because I said, you need to read this. He wrote this foreword, and he was so excited because James Mattis had called him. So I'll call him back. But Marines love that man, and he's just to them just like the leader that they just look up to. But he's
How wonderful.
Well, I mean, this is a case of somebody that I was with the week when COVID made landfall. And he went through this retreat with me and a few other Marines that were there, and he's thriving in the global pandemic.
Cool.
I mean, you could hear it in his voice. He was one that needed an injection after 6 months again to get a second boost, because he went back into, at the time, a pretty difficult and challenging home environment. The second time around, we set things up differently for him so that in the after effect of this, he would have a much more supportive environment. And he's doing great. He sounded great.
Wow, this work you're going to do is going to just be so game changing. All right, I'll shut up and let other people comment.
So Gene, I have a question to ask you. So you obviously do lots of thousands of stellate ganglion blocks, and Shauna has a very nice protocol. And I think all of us that deal with chronic pain realize that everything we do is just one tool in a group of things that we do to help solve a patient's problem. So I don't think any of us think the stellate ganglion block is going to cure pain. Obviously, the structure that Shauna provides is wonderful, but you must do blocks for people that don't provide that structure. You must see a difference in those outcomes.
So hold on. So you're combining two of the things that I've been doing, right? There's pain medicine and there is PTSD medicine.
Okay.
Right. So people ask me, so is this a cure for PTSD? My answer is no. There's no cure for PTSD. Are you familiar with CRPS, complex regional pain syndrome? As an orthopedic surgeon, complex regional pain syndrome?
So what was the question?
Complex regional pain syndrome. Are you familiar with that?
Oh yeah, very familiar.
Okay, so if you catch it early, you do a couple of blocks, it stops.
Right.
But I tell people you are likely to develop it again if you have another injury or something else. This is no different. So the point is, if somebody comes in and they want to get better, they have a supportive environment, even without the amazing capability of Shauna, they're going to do much better than somebody who's a lone wolf out there and he has no life, nothing, and he's poor on the streets, right? So people like that do not do as well. So in an ideal environment, you want somebody with Shauna intervention before and after, and they want to have a place, they need a place to live, they want to have a job. Those people do a lot better than the ones who have no job, no life, and no food, right? I don't know if that answers your question.
Yeah, no, it does. I mean, I just think the emphasize, and I think this whole group thinks the same way, that it's all about safety versus threat. And providing that social network to provide safety is a huge factor. And that's where, of course, in medicine right now, we're throwing pretty quick procedures randomly as symptoms, not really taking care of the whole patient. So to me, whether it's, an epidural or physical therapy or counseling, it's all just part of a big picture. And so it sounds like, Shauna, you're providing a big part of that picture. And again,
yeah, but again, you're trying to use a pain model you're familiar with a psychiatric model. They're not the same. Because I'll give you an example. If somebody has a back pain, they can lie down and be comfortable, right?
Well,
With
no.
PTSD, you're miserable all the time.
So, Gene, I would invite you to come to our table every week because all of us do not think that. We think that the chronic physical disease and mental disease are the same soup. Do you already want to comment on that? Because I'm going to get myself in trouble here. But no, we honestly, I'm serious about this, is that DR and Steve Porges have taught us really clearly that anxiety, depression, schizophrenia are all inflammatory disorders. Same thing with Parkinson's, Alzheimer's, cardiovascular disease, diabetes are all inflammatory. It's actually the same soup. And we think PTSD is solvable. We see that all the time. We think chronic pain is solvable. But again, it's that whole process of creating safety, both socially, personally, and within the family, is about connection and creating the sense of safety and control. So I'm still intrigued by Dr. Danzer's paper out of Austin. He says there's 4 things, I'll use the word psychological, even though I don't like that word anymore either, is that the 4 things that make a difference in the immune system, there's a bunch of things that affect the immune system, but the mental threats are a bigger problem than the physical threats because you can't escape your thoughts. But he pointed out the first thing is sense of control. Second was optimism or sense of hope, which I think the sympathetic blocks actually address.
Yeah.
The third thing was positive affect, and the fourth thing was social connection. So there's lots of literature, again, from his review paper, which is remarkable, about those 4 factors directly affecting the immune system. So Les, you want to help me on this one as far as we think PTSD is solvable. We see it solvable pretty regularly. And,
Oh yeah, I agree with that completely.
Yeah,
Right.
we think it's an injury and that it's
Yeah.
something
It's
that if
biologic,
we thought
right?
it's an injury with psychological and emotional components, that this fused model will get people long-term relief.
So as a pain guy, I really have to comment on this though. I got to tell you.
You have to
And you guys are probably all going to disagree with me, but I have to say it. So again, as an orthopedic surgeon and somebody who's worked on, let's say if you have a ruptured disc, right, that's compressing in the nerve root, there is cytokines attacking the nerve. It hurts like a mother. They have a loving family. They have a psychology holding their hand. They've done mushrooms. They're screaming in pain on a continuous basis. They cannot stop screaming. So I do not believe, I mean, I know that I'm giving an extreme example. Chronic pain, by definition, at least the way I was trained, is that there is no underlying acute pathology you have to deal with, right?
No,
That's all been said. That's all been solved. Or am I wrong on this?
you're wrong. And
Wow.
when I say that humbly because I mean, 5 years ago, there's a bunch of data out that just speaks the opposite. I had the data says and Jim can actually support me in this one. Jim, you're being remarkably quiet, by the way. Jim's actually one of my most difficult friends, by the way. So thank you, Jim, for leaving me alone for a second.
Phone is broken.
Anyway, what I'm saying is that there's data shows that bone-to-bone, hip, knee, and shoulder arthritis do not correlate with pain, which is remarkable. The data says if you operate in the presence of untreated chronic pain, you can induce chronic pain or make it worse 40 to 60% of the time with the
I
perfect.
agree completely. That's true. I believe that.
Right. So we also are working with UCSF right now with Sig Bourbon, where we're taking and doing prehab on every patient, not quote to psychologically make them better, but to drop the inflammatory markers. When I started doing prehab about 7 years ago, I had over 120 patients with extreme spinal stenosis, not soft disc ruptures, horrible leg pain, claudication, the whole thing, canceled their surgeries because their pain disappeared. Blew me away. So remember
Is that published?
what's that?
Can you send me that?
I set up an abstract. We presented in Argentina and we collected the names. My fellow never published it. And, but yeah, it happens all the time. And so even Les Aria with this whole approach, a polyvagal approach, inadvertently, we found out that actually what we're doing is the polyvagal approach. It's simply calming down the system. Because what happens is we drop the inflammatory process down, it changes the nerve conduction, pain disappears. My surgical rate dropped down to 4.5% the last 5 years of my practice. My infection rate dropped almost to 0. And I was doing these massive 10 and 12 hour surgeries, but I didn't realize that this prehab that we call it actually drops down the cytokines and inflammation and improves tissue healing. So then I talked to my fellow I trained 3 years ago, and he's rehabbed his deformity patients. He operates on about 5 to 10 deformity patients a year, where his partners are doing 40 and 50 a year. But as he does the prehab and calms down the nervous system, calms down the inflammatory response, pain disappears, structural or not. But I did write a book called Do You Really Need Spine Surgery? It looks at structural versus non-structural. I actually quit my surgical practice because probably 70% of spine surgery is done on normal spines for their age. So with this structural problem, I'll grant you surgery works. I did do surgery. We did the prehab on every patient every time. And they would come in for the final visit. I thought they were surgical. I historically did surgery on them until 3 years ago. And they come in with their pain gone. I'm going, excuse me? So it was remarkable. So anyway, the data shows, well, we do know the risk factors for poor outcomes are anxiety, catastrophizing, et cetera, which I now know through Steve Porges and D.R. Clausen, those are actually inflammatory issues that actually crank up the nervous system and make the pain worse. So with the prehab, so the data says if you operate in the presence of untreated chronic pain, that even with the perfect operation that's indicated, the pain gets worse 40% of the time, which I had that experience myself. That didn't happen the last 5 years of my practice. So as we calm people down, we essentially had no failures if the operation was done technically well. So it's unbelievable. I mean, I'm totally shocked when that started to happen. And so that's what's different about this group, is that we're seeing that you can literally rewire your brain around almost anything. Anyway, that's I get on my pulpit there. Sorry, group.
Well, I'd like to see whatever the data you got on that. I'm not familiar with that.
Yeah.
You have to understand,
Can I get a word
I'm basically trained as a pain doctor.
Yeah, no, I know. I mean, when I see bone arthritis, I go fix it. And the data shows there's about 5 major papers that show that the severity of pain with arthritis does not correlate with the severity of the arthritis, actually correlates with stress. So Les, will you bail me out here a second?
Yeah, I just have 2 comments. I think it's time we leave Descartes' common sense model in the past. That's my first comment. Having have pool buddies and beer buddies who are pain MDs and hanging out with them, I propose 2 things. One, when we treat chronic pain, it should not be biopsychosocial. It should be psychosocial bio. Any chronic medical condition should be revamped in that manner, where biological stuff does work, but when we address the psychosocial factors, we actually calm the nervous system down. And the other part I want to comment, besides leaving Descartes' model, flipping how we see the biopsychosocial model for chronic pain or disease, it should be psychosocial bio. And then the last comment is, I say, send us a patient that anyone wants to work on, and then let me have at that. And I want to show you something that we can flip this around. I do this all day long with wonderful human beings like us and wanting to help patients. And it's not that one of us is wrong or right. It's just that when we hit a brick wall, we need to know how to go around it.
Yeah, I think, I kind of like the biopsychosocial less, because as a psychologist, to me, I see that people sometimes get locked in a state that is an injury. And so sequencing them that way, when we address the biological piece and then we pull in the psychosocial piece, has actually been, for me, a really productive model for getting people to healing and helping them maintain the healing.
I agree with you 150%. Yeah. However, my tenet was not on that. My tenet is not at all. So I always I always want the MDs to clear everyone, make sure there's no cancer, as an encephalitis or something like that. And then, but the psychosocial part was the emphasis of treatment, meaning that when we look at this, if we treat the psychosocial factors, any surgery done or injections done, I do this with my physiatrists or pain MDs, before they stick a needle in them, they've tried it once or twice, and the 3rd time I said, before you stick it in, let me work with them for 2 weeks.
Yeah, I agree with you on that.
But I think we are meshing pain medicine and psychiatry, right?
Yeah.
PTSD.
It's one system.
It's one system, Gene.
Let me jump in for a moment, because I think we're missing a real opportunity to conceptualize something very important based on Gene's work. Gene's work is telling us that there's a hierarchy of how these systems work. And if you can downregulate this high-level aspect of the sympathetic nervous system, the emerging properties are this socialized human being. It's a natural point. Now, what's important is that within polyvagal theory, the focus was on the highest level being the social engagement system, the calm system. But it's clear that with PTSD, at least the PTSD clients that you're working with, that system is long gone. It's not accessible, it's dormant, it's put to sleep. Right. So there is, in a sense, in a hierarchical model, and this is something that Gene and I talked about almost a decade ago, there's a retuning of the system.
Yeah, it's
with
coming
this.
online. It's coming
Yeah,
back
but
online.
what's interesting, and this is where I need more, sense comparative neuroanatomy and evolutionary understanding, and that is this part of the sympathetic nervous system? Does it come in very late during evolution, during vertebrate phylogeny, that then enables it to be inhibitory over what I call the social engagement system or the ventral vagus? And I think that is the case, but I think it's not recruited. It's not a natural thing to recruit. And this is where you get into the neural growth factor. It's something that has occurred doing some aberration in how the system was supposed to work, and it gets stuck in that state and it supports it. But it's a hierarchy. Once it's there, these other systems are not available.
And I know this is going to sound like off the wall, but like one of the ways that warriors kind of regulate each other and help each other maintain and keep their stress lower is through humor.
Yeah.
So the call, I just got a second call from another Marine, and it's like, I hope this isn't offensive, because it's not offensive to me because I know his heart, but he was just calling me. He's multiracial, including African American, and we're like brother and sister. And he said, "I'm just calling to check on your white fragility." And I'm like, "What? Excuse me? I'm just calling to check in on your white fragility." And like, I was like, "Let me call you back." But like that kind of interaction that I get to have all the time with warriors and how they interact in their circles, it regulates pain. It metabolizes pain of a psychological nature.
See, Les, this is why my patients are getting better, is because my sense of humor.
There you go.
That's it.
Yeah. But after a while, they get stuck and it becomes an injury. And that's where, yes, Stephen, I think Gene's work is so innovative.
So, Gene, it's a bit of a story, and I welcome you to join us. But I've learned more in 4 months than I've learned in 30 years about this whole thing. So I'm just blown away with the whole nervous system, the midbrain, the polyvagal therapy. This is extraordinary tonight, actually learning what you do. And I think you and Sean already know this, is your block in the context of an overall care plan, which helps safety. And it feels like this is a very strong entry point into a very difficult problem that we face. And I think what you'll find interesting is this whole other structure we put around it that really has been helping people feel safe enough. And we want people to go to pain-free all the time, including PTSD. And so it's been remarkable, totally surprising. Again, I actually quit my surgical practice because of this. And I was blown away with what's going on. So it's been really, this roundtable has been extraordinary for me personally. And again, tonight was extraordinarily helpful for me to just get a whole different feel for what's possible. I think this is fantastic what you're doing.
Hey, Dave.
Yeah.
This is DR. I just wanted to throw in my typical 2 cents, but when we're trying to get to a one system model, I think it's important to keep in mind that every psychiatric diagnosis that we know of, the root cause of it is underlying it is threat. And every psychiatric diagnosis we know of has elevated pro-inflammatory cytokines.
Right.
And people with chronic pain, with chronic social disease and illness, such as discrimination and social injustice, tend to have elevated pro-inflammatory cytokines. And I think I was listening to this, there's something that I can't really say for sure, but it reminds me a little bit of migraines, where under acute stress, we get this phenomenon, this sort of wave that's been called various things. And, I think a long time ago, we thought it was all vascular, and then we thought it was all neuronal. I personally believe it's the wave of a migraine is mediated by the glial cells and the release of pro-inflammatory cytokines, and they subsequently have an effect on the vascular beds and the neurons and the trigeminal ganglia and all that, and cause pain. But it tends to come on as sort of a rush across the glia of the brain. And this reminds me of almost causing a retreat of that phenomenon, where everything quiets down. You're taking, probably adrenaline, noradrenaline, backing it down. You're backing down the cytokines. I know there's the discussion in pain literature, including migraine literature, about nerve growth factor and brain-derived neurotrophic factor being a part of that. I think the cytokines are probably a bigger part. But I feel like this is like this opportunity, and these cytokines that are sort of chronically circulating when people are under a constant sense of threat and stress, their half-lives are pretty short. So if you can get a 6-hour block, you may be able to get a significant change in somebody's physiology for a while, that, as Steve says, maybe enough of a window to get the vagal system to sort of reassert itself. Anyway, I'll just throw that out there. It's kind of the typical thing I usually say about cytokines.
I appreciate that. So 6:08, we're going to stop. And Gene, this is phenomenal. Shauna, this is phenomenal. Thank you both for presenting. I mean, really, a whole new set of concepts opened up to me. I always thought the blocks went from distally down. I had no idea it worked on the central nervous system. And Steve, I didn't really understand, the difference between, the parasympathetic system and this being the overload to block that overloaded system. So any final comments, Gene and Steve and Shauna?
Well, I just have one.
I'll be back on next week to listen to what other exciting things happen.
Well,
you haven't even heard about the oxytocin part. Wait till that comes on board. That's
Yeah,
really,
I'm looking forward to that.
so my only comment is this has rekindled my interest in looking for a newer mammalian branch of the sympathetic nervous system. And I think the superior cervical ganglia was my pick when I started to think about this 20 years ago, but I kind of put it aside. So I'm going to go back.
Cool.
And if anyone can help me find in the literature the evolution of the cervical ganglia,
I'm going to look for it, Steve. Now, after this discussion, I gotten all type of fires on my butt. I'm going to look for it now.
Wonderful.
Go ahead.
No, actually, Gene, we're going to talk together on Friday, so we'll discuss some more things.
And Shauna, any thoughts from your perspective?
I was just going to say whoever finds it first gets to name it, but no. No, this is just, it's fun. It's fun to have this kind of conversation and get to share the work that we do. And I always just think, all of this really comes down to helping people live to their potential and saving those we can save. And so I want to understand these things, but at the end of the day, I'm always asking myself, is what I'm understanding going to help me save the life of somebody that's precious? So thank you for letting us share. And
Really fantastic. Good stuff. All right. Thanks, everybody. Good
Thank you.
stuff. All right. Thank you very much.
Bye-bye.